Hi, I'm Dr. Robinson, and I'll be reviewing the oxygenation content for this unit. Please take time to complete the reading associated with the unit and review the key terms and objectives. The respiratory system is divided into the upper and lower respiratory tracts. You should be familiar with the components in each part of the system and their function. The respiratory system is responsible for transferring gases between the atmosphere and the blood. Oxygen is a gas that makes up 21% of the air that we breathe. Cellular metabolism produces carbon dioxide, which must be eliminated from the body. The process of breathing occurs through respiration, or ventilation, the first part of the respiratory process. Ventilation is the process of moving gases in and out of the lungs. The amount of air inspired and expired with each breath is known as tidal volume. In an adult, about 500 mLs of air is inspired and expired with each breath. Normal breathing should require little to no energy. Expansion and recoil occur passively in response to pressures within the thoracic cavity. The diaphragm also plays a role in respiration by contracting and moving downward, allowing the lungs to expand and fill with air. The diaphragm is a major inspiratory muscle of respiration and is controlled by the phrenic nerve. Workup breathing is the effort needed to expand and contract the lungs. Normally, breathing is quiet and is accomplished with minimal effort in a normal, healthy adult. We monitor the patient's rate and depth of breathing and their ease of breathing. We know that patients are working harder than normal to breathe when we see abnormal posturing, use of accessory muscles, nasal flaring, grunting, or an increased rate of respiration. In order to have an adequate ventilation, the lungs need to stretch, and this is called lung compliance. The workload of breathing would become more difficult if lung compliance or stretch was compromised. The lungs need to be able to rebound with each breath. This is called lung recoil. If there's a problem with one or several of these areas, the patient's ability to breathe and perfuse their tissues with oxygen will be compromised. Diffusion is the movement of gases or other particles from an area of greater concentration to an area of lesser concentration. This is the second phase of the respiratory process. Oxygen diffuses from the alveoli into the capillary network surrounding the alveoli and thus entering the bloodstream and will be perfused throughout the body in an effort to deliver oxygen to the tissues. The third part of the respiratory process is the transport of respiratory gases. The alveoli are located at the terminal end of each bronchiole. The alveoli have very thin walls, and each alveoli is surrounded by a network of pulmonary capillaries. This is where gas exchange occurs between the air in the alveolar side and the blood in the capillary side. The animated graphic demonstrates how oxygen is transferred from the alveoli into the bloodstream through a capillary membrane that's composed of only one single layer of epithelium. The rate and depth of respirations is adjusted when the change in CO2 level is detected. Oxygen transport is affected by the following: cardiac output, because adequate perfusion is dependent on adequate cardiac output. The amount and quality of red cells, because red cells carry oxygen molecules. Exercise, because this will increase oxygen demand. If there's a decrease in cardiac output, the oxygen delivered to the tissues will also be decreased. The heart will try to compensate by increasing the heart rate. You need to understand how the body will compensate in order to maintain homeostasis. A few conditions that can cause a change in cardiac output include damage to the heart muscle, pooling of blood, and blood loss. Exercise is good and it improves perfusion because it increases cardiac output, but it also requires more oxygen. Erythrocytes are red blood cells, or RBCs, that contain hemoglobin. The red cells are a biconcave shaped disc like a donut. They're very flexible, which allows them to navigate through the capillaries. The red cells have a very thin cell membrane that facilitates the absorption and release of oxygen molecules. Red blood cells live about 120 days. Hemoglobin within the red blood cells carry oxygen from the lungs to the tissues and transport carbon dioxide from the tissues back to the lungs. Diffusion of respiratory gases occurs at the alveolar capillary membrane. Red blood cells, or RBCs, this test measures the quantity of red blood cells. Hemoglobin, or HGB, is the amount of hemoglobin contained within each cell. This is an important part of the red blood cell because it's a functional unit that carries the oxygen. Iron is also needed to form hemoglobin, so insufficient amounts of iron will also affect the patient's oxygenation. Hematocrit, HCT. This is the percentage of red cells compared to the liquid or serum portion of the blood. This test is affected by the patient's hydration status. When we report hemoglobin, we always also report hematocrit. We report these tests together. Here are some conditions that you will see high and low hemoglobin levels. When we assess breathing, we assess rate, depth, pattern, and effort of breathing. You should become familiar with the different patterns of breathing. This slide reviews some of the different patterns of breathing that you will assess in your patients. If I told you that I heard vesicular, bronchovesicular, or bronchial breath sounds in the areas noted on the slides, you should understand that I'm hearing normal breath sounds over each of these areas. You need to become familiar with different types of abnormal breath sounds. Adventitious breath sounds, or abnormal breath sounds, occur when air passes through narrowed airways or airways that are filled with fluid or mucus. Absence of breath sounds over some areas of the lungs is a significant finding and can be associated with a collapsed lung, surgical removal, or severe pneumonia. Rhonchi are caused by the passage of air through mucus. These may be cleared through coughing. Crackles are caused by the passage of air through fluid or a mixture of fluid and mucus. Wheezing is caused by the passage of air through a narrowed airway, causing a musical sound. Wheezing can be heard only in inspiration, only in expiration, or it may also be heard on inspiration and expiration in patients with a more severe narrowing of their airway. Atelectasis is the collapse of the alveoli. A collapse of these air sacs will prevent normal exchange of oxygen and carbon dioxide. Atelectasis can be caused by mucus, a tumor that's blocking your airway, or by pressure from outside the lung that keeps the lung from expanding. Asthma is a condition when a person has airways that are inflamed and narrowed due to swelling, in addition to the lungs producing extra mucus. All of these changes make breathing more difficult for this type of patient. COPD, or chronic obstructive pulmonary disease, is the general term used for a group of disorders that are characterized by impaired airflow to the lungs. Emphysema is characterized by enlargement of gas exchange airways and damage to the alveolar walls in the lungs. Air becomes trapped in the lungs, causing hyperinflation of the chest due to loss of elasticity. The major cause of this is cigarette smoking. As you can see, there are several things that can cause impaired respiratory function. Fluid, mucus, and inflammation can interfere with gas exchange, respiration, and eventually perfusion. Mild impairment of oxygenation can cause fatigue and irritability. Severe alterations can result in tissue hypoxia, which can become life-threatening. Hypoxemia is defined as a decreased level of oxygen. Cyanosis is a late sign of hypoxia. Clubbed nail beds is an indicator of chronic hypoxemia. Lack of oxygen may also affect the patient's comfort and can cause pain. Clients with pain may also have an increased heart rate, increased respirations, restlessness, anxiety, and diaphoresis or sweating. Compensation is the actions that your body takes to make up for having less oxygen. Tachycardia is one compensatory mechanism that the body can use to increase the delivery of oxygen to the body's tissues. Tachypnea is an increased respiratory rate that can be seen in patients that are trying to compensate for decreased levels of oxygen. When decreased oxygen levels are due to anemia or blood loss, the body compensates by increasing the systemic workload, and the body will shunt blood from the periphery to the vital organs. Clients with impaired oxygenation may have fatigue, pallor, jaundice, and tachycardia. They may also experience cognitive impairment. They may have memory loss, slurred speech, or may appear incoherent. Here is the box from your functional dimension care plan. The items listed on the slide are the respiratory assessment items that you should look at in your patients. The oxygenation box in your functional dimension care plan assignment documents both cardiovascular and respiratory assessment items that help us to assess the oxygenation and perfusion. You need to put both normal and abnormal findings here. You will highlight any abnormal findings. These highlighted items become your AEBs, or your as evidenced by items in your NANDA diagnosis statement in this functional dimension care plan. Here are some examples of NANDA diagnosis for the respiratory system and some associated symptoms. You need to be sure that you have evidence, patient symptoms or AEBs, that substantiate the NANDA diagnosis that you've chosen. For example, if I state my patient has activity intolerance and I tell you that the evidence I have for this is that they have thick secretions, the NANDA diagnosis and the evidence for the NANDA diagnosis do not match. But if I tell you that my patient has activity intolerance and my evidence is that the patient stated, "I'm out of breath when I get dressed," the NANDA diagnosis and the evidence are in alignment. Here are some interventions that can be used to enhance oxygenation in your patient. This is the planning intervention stage of the nursing process. Once these measures are implemented, you will also need to perform an evaluation to decide if these interventions were effective and if they were helpful in meeting your patient's long and short-term goals. Each heartbeat is a combination of a contraction during systole followed by relaxation during diastole. With each contraction, during the systolic phase, the heart is able to squeeze and eject or forcefully push blood into the pulmonary and systemic circulation. The ventricles fill during diastole, or the diastolic phase, which is also the resting phase of the heart. In a normal cardiac assessment, you should hear lub-dub, or S1, S2. This is normal. The first time you hear S1, or lub, which is the beginning of the ventricular systole, this sound is caused by the closure of the tricuspid and mitral valves, also known as the AV valves. The second sound that you hear is S2, or dub, which is the beginning of the ventricular diastole and is caused by the closure of the pulmonic and aortic valves, also known as the semilunar valves. The base of the heart is located on the top of the heart, and the apex is the bottom of the heart. This information will help to guide your assessment of these cardiac sounds. You need to know the formula for cardiac output. Cardiac output is defined as heart rate times stroke volume, or the amount of blood ejected with each heartbeat. Anything that decreases cardiac output will decrease the amount of oxygen delivered to the tissues. The heart compensates for inadequate output by increasing the heart rate. Compensation may be exhausted if there is severe damage or extreme blood loss, and the compensatory mechanism may not be able to adequately restore the blood flow and the oxygen to the tissues. You should know the normal pattern of blood flow through the heart. Normally, arteries carry oxygenated blood away from the heart to the body. Veins carry unoxygenated blood back to the heart. However, there is an exception. Pulmonary arteries carry unoxygenated blood from the right side of the heart to the lungs, and the pulmonary veins carry oxygenated blood to the left side of the heart from the lungs. You should also review the modifiable and non-modifiable risk factors for cardiovascular disease that are listed in your chapter. Okay, so let's talk about preload and afterload. Preload is the amount of blood in the ventricle at the end of diastole, or the end of the contraction. When you think about preload, I want you to think about stretch. The ventricles stretched when they're filled with blood. The greater the stretch, the stronger the contraction, resulting in a greater stroke volume. Exercise causes increased venous return and therefore increases preload. In response, the heart contracts more forcefully, causing the stroke volume and the cardiac output to increase. Fever can also increase heart rate, but remember the ventricles need to fill when the heart's resting in diastole. If the heart rate is too fast, the stroke volume will be decreased due to inadequate filling of the ventricles, and a decreased cardiac output will be the result. So remember that an increased heart rate does not always mean there'll be improved cardiac output. Preload can be altered with some medications and some medical conditions. Decreased preload is seen in dehydration and hemorrhage because there's a decrease in volume, resulting in a decreased stroke volume and ultimately a decreased cardiac output. By giving fluid to the dehydrated patient and replacement of blood to the patient that's hemorrhaging, the circulating volume is increased, resulting in an increased preload and increased stroke volume, which will ultimately result in an increased cardiac output. The goal of therapy would be to restore normal blood pressure, normal pulse, and organ perfusion. An increased preload is seen in patients with hypervolemia, regurgitation of cardiac valves, and heart failure. Increased stretch is seen in these patients because of these conditions. Excess preload increases the heart's workload as well as the myocardial oxygen demand. The cardiac muscle will need more oxygen. Contractility is the ability of the heart to squeeze and push out the volume of blood contained in the ventricles. So contractility refers to the strength of the squeeze. If the heart is able to contract well, the stroke volume, or the amount of blood ejected with each contraction, is about 70 mL per beat for the average adult. Contractility is affected by the autonomic nervous system. Drugs prescribed to alter contractility are called inotropic drugs. Positive inotropic drugs increase heart rate. Negative inotropic drugs decrease heart rate. Several conditions can affect the heart muscle and the ability of the heart muscle to contract and pump. Myocarditis is inflammation of the cardiac muscle. It can be caused by viruses, bacteria, parasites, and fungal infections. Other causes include medications, like allergic or toxic reactions to chemotherapy, antibiotics, anti-seizure medications, and some illegal substances like cocaine. Cardiomyopathy is disease of the heart muscle that makes it harder to pump. Some reasons why they might develop this would be long-term hypertension, damage from a heart attack, heart valve problems, and metabolic disorders caused from thyroid problems, and pregnancy complications are just a few examples. These diseases can result in impaired muscle contraction of the heart. Afterload is a resistance the heart ventricles must overcome during systole to eject the blood into the circulation. When you think about afterload, I want you to think about resistance. The right ventricle pumps blood into the pulmonary circulation, and the left ventricle pumps blood into the systemic circulation. The ventricles must have enough pressure to overcome the vascular resistance so the blood can fully be ejected from the ventricles. The right ventricle delivers blood to the pulmonary circulation, which is normally under low pressure conditions. The left ventricle must overcome the higher systemic pressures, resulting in an increased workload that can be further complicated by hypertension and vasoconstriction. The higher the afterload, the harder the heart must work in order to eject the blood, resulting in an increased myocardial oxygen demand. Adequate perfusion is dependent on three things: an adequate blood supply, a good pump or our heart, and good vessels. Our blood must be pumped all the way to the capillaries, which allows gases and nutrients to be exchanged. The valves of our heart help to keep blood moving forward and prevent regurgitation. The picture in this slide shows normal and abnormal variation of valves. We also have valves in our veins to help keep blood pumping forward, back to our heart, and promote venous return. Encouraging patients to walk or to do foot pumps are also ways you can help your patients promote venous return and avoid stagnant blood or venous pooling. Here's the box from your functional dimension care plan. The items listed in the slide are the cardiac assessment items that you should assess in your patients. You need to put both normal and abnormal findings. You will highlight any abnormal findings. Remember that these highlighted items become your AEBs, or your as evidenced by items in your NANDA diagnosis statements in this functional dimension care plan. The heart is a pump that delivers oxygen to the organs and tissues via arteries and returns CO2 to the lungs via veins. The heart muscle has a network of vessels known as coronary arteries that bring oxygenated blood to the heart muscle itself during diastole, or when the heart is relaxed and not beating. Obstruction of these vessels can be caused by a blood clot, plaque, or buildup as seen in coronary artery disease, which is abbreviated CAD. Any blockage can deprive the myocardium of oxygen and result in angina or chest pain, which can further lead to a myocardial infarction or heart attack. Adequate oxygenation and perfusion is dependent on the cardiovascular system and respiratory system working adequately together. Adequate perfusion is dependent on the ability of the cardiovascular system to pump oxygenated blood to the tissues and return deoxygenated blood to the lungs. The assessment items listed in this slide will help you identify if your patient has adequate perfusion. Impairment of blood flow will result in tissue ischemia that will eventually lead to necrosis if it's not caught in time. This slide reviews some of the causes of tissue ischemia. You will find the 6-piece assessment helpful to use in the clinical setting when you are trying to assess if your patient has adequate perfusion. Be sure to complete this assessment on any patient that has an extremity injury, surgery to a site, medical condition that would affect perfusion to an extremity. Here are some more NANDA nursing diagnosis and some associated symptoms for cardiovascular conditions. Remember that your evidence must match your NANDA diagnosis. Here are some interventions that can be used to enhance oxygenation in your patient. This is a planning intervention stage of the nursing process. Once these measures are implemented, you will also need to perform an evaluation to decide if these interventions were effective and if they were helpful in meeting your patient's long and short-term goals. Many patients are diagnosed with hypertension. Remember that we never diagnose a patient based on one finding. For example, if a blood pressure is taken and the blood pressure is elevated, we would need to gather several readings before a patient is diagnosed with hypertension. You should become familiar with the risk factors for hypertension so that you're able to identify which patients you are caring for are at a higher risk of developing this condition. Long-term patients with hypertension can progress into heart failure. We need to remember that many patients with hypertension have no symptoms. It's important for the nurse to teach the patient about their condition, about their medications, and how to take control over this condition. Medication compliance is essential to controlling this disease. Some of the treatments used are outlined in this slide. Dietary and lifestyle modifications also play a role in controlling hypertension. If a patient's heart is not strong enough to pump blood forward, there is a backup of blood that can cause stretching of the ventricles. We can do a test called a BNP, brain natriuretic peptide. Brain because this is where the hormone was first discovered. This hormone is secreted by the ventricles when the ventricles are stretched due to overfilling. We can measure BNP levels in our patients that we think have heart failure to diagnose them, and in our heart failure patients to monitor their care. The symptoms of left-sided heart failure are related to the backup of fluid, and the symptoms of right-sided heart failure affect the rest of the body. We can listen to our patient's lung and monitor for crackles, which is a symptom found in left-sided heart failure. The patient may also develop an extra heart sound, an S3, due to overfilling of the ventricles. We may give patients with heart failure a drug called Lasix or furosemide, a diuretic to help remove excess fluid. Patients receiving Lasix should be monitored for changes in potassium levels since this medication can cause a decrease in potassium levels. The treatment for these conditions are listed on this slide. Digoxin is a drug that is very effective in this population. This drug is known as a positive inotrope. It has two effects. It improves the contraction or squeeze of the heart to make the heart pump more effectively. It also slows the heart down, which allows the ventricles to fill more adequately and results in improved stroke volume and cardiac output. How do we assess a patient receiving digoxin? We, the nurse, not the tech, should obtain an apical heart rate for 60 seconds. We hold digoxin if the patient's heart rate is less than 60. Here's a list of some additional medications that we may use. Some patients can develop a DVT or a deep vein thrombosis, a problem with the pipes or delivery system that will result in a diminished amount of blood, oxygen, and nutrients to the patient's extremity. Patients are at risk for developing this condition if they have venous stasis or pooling of blood in the lower extremities that can be caused by long car rides, long airplane flights, immobility, patients confined to bed rest. In addition to the lack of blood supply to the extremity, the clot or blockage in the extremity can travel to the lungs, causing a pulmonary emboli. Other complications are listed on the slide. The key to this diagnosis is prevention. We want to prevent venous stasis or pooling of blood in the lower extremities. We want to change the patient's position every 2 hours. The following measures are intended for prevention of DVT in your immobile patients and should not be performed on patients with an active DVT. Do not massage a patient's legs if there is any concern that they have a DVT. If we can get our patients up after surgery, we try to get them up and moving, or at least get them up to sit in a chair at the bedside. For prevention, we can use the TED hose or compression stockings. We can encourage our patients to do foot pumps that mimic walking and promote the venous return. SCDs or sequential compression devices help to massage the patient's legs and prevent venous pooling. Some patients will also have the administration of heparin or low molecular weight heparin. Here's a great way to remember which lab test is associated with each of these medications. There are 7 letters in heparin and 3 letters left out of 10, so the test used to monitor heparin therapy is PTT, partial thromboplastin time. There are 8 letters in Coumadin and 2 left out of 10, so the test used to monitor Coumadin therapy would be PT or prothrombin time. When you are learning each medical condition, you should also consider lifespan considerations for each diagnosis. In Level 1, we only address conditions found in adult patients. Please be sure to review how a patient's lifespan considerations will change the assessment findings. This slide reviews some of the respiratory and cardiovascular changes that would be seen in older adults.